In this session, we will look at how reproductive and child health programs have evolved in India over time. The lecture will not just provide a list of programs but also explain why these programs were launched when they were. You will learn how India's health priorities shifted in different decades. This will give us a sense of how social, political, and economic contexts influenced health policy. By tracing this evolution, you will understand how today's programs have roots in their initiatives. Finally, you will gain the ability to critically analyze what has worked well and what still needs improvement in the area of reproductive and child health. Reproductive and child health has always been one of the most important areas in public health in India. The reason is simple: mothers and children make up a large part of the population and are more vulnerable to disease and death. When India became independent, maternal and infant mortality were very high, so the government had to respond. Over the decades, the way India approached this issue has changed a lot. Initially, the focus was mainly on population control, but later the approach became more comprehensive. Today, the idea of reproductive and child health includes rights, empowerment, and access to a wide range of services. By reviewing this journey, we can appreciate the progress and understand the gaps that remain. The Boer Committee report in 1946 is the intellectual blueprint of India's public health system and the earliest formal push towards comprehensive primary health care with MCH at its core. It argued that the state must guarantee universal access to essential services, integrating preventive, promotive, and curative care rather than running them in slots. The committee envisioned a tiered network rooted in the village, sub-center, dispensary level care, linked upward to primary units, and then to well equipped referral hospitals, so that complications in pregnancy, childbirth, and infancy could be managed without catastrophic delay or expense. It it explicitly prioritized maternal and child welfare, school health, control of communicable diseases, safe water and sanitation, and nutrition, of course, recognizing these as the foundations of population health. Training of new kind of clinician was recommended to shift practice from episodic treatment to continuous family and community care. The report also framed health as a development investment, urging governments to budget for rural services, transport, and housing for staff to make outreach real. It emphasizes on integration and equity, foreshadowed Alma-Ata by 3 decades and directly influenced post-independent policies from primary health centers network to later MCH family planning, CSSM, and ultimately RCH and RMNCH plus A. Today we are operationalizing Bhore's central idea: reliable, publicly financed first contact care that protects mothers and children and links them seamlessly to higher levels when needed. When India became independent in 1947, it faced enormous health challenges. The government used 5 year plans as a way to organize development, and health became a part of this. Maternal and child health was included early on, but the most notable step was in 1952 when the National Family Planning Program was launched. This was historic because India became the first country in the world to adopt such a program at the national level. At the time, population growth was seen as a barrier to development, so reducing fertility was a main concern. The program began with a focus on birth control methods and awareness. Though limited in scope, this marked the beginning of government led reproductive child health programs in India. By the 1970s, it was recognized that young children needed a holistic approach to grow and thrive. Healthcare alone was not enough. They also required adequate nutrition, early learning, and supportive care environments. In 1975, the Integrated Child Development Services Program was launched, marking a transformative step in India's social policy. It combined supplementary nutrition, preschool education, immunization, health checkup, and health education under one integrated network. The program operated through community based workers, Anganwadi workers, who served as the critical link between families and services, ensuring direct engagement with mothers and children. Over time, ICDS grew into one of the largest outreach programs in the world, covering millions of children and women. It demonstrated how convergence across health, nutrition, and education could simultaneously improve survival, development, and early learning outcomes. Importantly, ICDS also became a platform for women's empowerment by creating local employment and strengthening maternal awareness about health and childcare. The success of ICDS inspired several global models of integrated early childhood development and remains a cornerstone of India's commitment to human capital formation and inclusive growth. In 1992, the Child Survival and Safe Motherhood Program CSSM was introduced as a landmark initiative that brought child and maternal health together under one umbrella. This was a major shift because until then, the two areas were treated separately, often resulting in fragmented services. The CSSM program promoted essential interventions like immunization, oral rehydration therapy, and emergency obstetric care, which were key to reducing mortality and morbidity. It also strengthened safe motherhood services, emphasizing antenatal care, skilled birth attendants, and postnatal care to prevent maternal deaths. This integration was recognition that mothers and children's health outcomes are inseparably linked. Improving one directly influences the other. CSSM provided a strong foundation for the later reproductive and child health programs that followed. Moreover, it encouraged decentralized and child health programs, planning, and intersectoral collaboration, which enhanced local accountability and innovation. The program also brought greater focus to capacity building of health workers and improved surveillance systems, both of which became core pillars in subsequent RCH phases. Coming to 1997, the first phase of Reproductive and Child Health Program RCH1 was launched, marking a major milestone in India's public health journey. It expanded the scope of services far beyond what the earlier Child Survival and Safe Motherhood program had covered. The inclusion of family planning, management of reproductive tract and sexually transmitted diseases, and adolescent health brought a truly integrated approach to reproductive health. The program aimed to be more client oriented and responsive to local needs, moving away from rigid top down models to bottom up approach. Decentralization allowed states and districts to plan interventions based on their specific health situations, ensuring that services reflected the realities on the ground. This was a shift from one size fits all approach to a flexible and community based strategy. RCH1 marked the true beginning of a comprehensive reproductive and child health framework in India. It also emphasized community participation through Panchayati Raj institutions, women's groups, and NGOs, recognizing that sustainable data driven planning and health improvements require local ownerships. It set the stage for evidence based policymaking in subsequent health initiatives. The second phase of reproductive and child health program began in 2005 and continued until 2010, marking a period of consolidation and expansion. It placed stronger emphasis on maternal health interventions, aiming to reduce maternal mortality through improved access, quality, and coverage of services. One of the flagship schemes under this phase was Janani Suraksha Yojana, which incentivized institutional deliveries through conditional cash transfers, significantly increased the facility based births. Child health services were also strengthened, particularly through the integrated management of neonatal and childhood illnesses strategy, which integrated preventive and curative approaches for both mother and children. Routine immunization coverage was expanded, monitored more closely, and linked with community based monitoring mechanisms. This phase introduced a sharper focus on measurable outcomes and accountability, supported by periodic facility surveys and household data systems. RCH 2 was also launched alongside the National Rural Health Mission, ensuring great convergence between maternal, child, and overall primary healthcare initiatives. Additionally, capacity building efforts were expanded for frontline health workers, ASHA, ANM, and Anganwadi workers to enhance community level mobilization and service uptake. This integration of financial incentives, community participation, and evidence based strategies laid the groundwork for India's subsequent progress in maternal and child health outcomes under the broader umbrella of National Health Mission. The National Rural Health Mission, launched in 2005, marked a landmark reform in India's public health system. Its core goal was to strengthen rural health infrastructure while integrating reproductive and child health services with broader primary care. The introduction of accredited social health activists created a strong community link between families and health facilities. These local women became trusted health advocates, link between families and health facilities. These local women promoted institutional deliveries, immunizations, antenatal care, and family planning. NRHM also emphasized decentralized planning, allowing each village to prepare a health plan tailored to the local needs and priorities. Community based monitoring mechanisms were established to ensure transparency and accountability in service delivery. Altogether, NRHM transformed the very reproductive and child services reached the rural populations by improving the access, participation, and trust. Additionally, it invested heavily in upgrading sub-centers, PHCs, and CHCs, ensuring the basic infrastructure and staffing standards were met. The mission also focused on intersectoral convergence, bringing together nutrition, sanitation, and water supply efforts under a single developmental framework. Over time, NRHM became the backbone of India's rural health delivery system, paving the way for its eventual evolution into the National Health Mission, which extended these principles to urban areas as well. The Janani Suraksha Yojana, it was launched under the RCH2 framework as a flagship initiative to reduce maternal mortality by promoting institutional deliveries. It offered conditional cash incentive to women from low income and marginalized families, encouraging them to seek professional care during childbirth. This intervention was particularly crucial in rural and underserved areas, where home deliveries without skilled assistance were still common. By linking financial support with safe delivery practices, the program successfully influenced health seeking behavior among women and families. Over time, this JSY It led to a remarkable rise in institutional deliveries across India, especially among the poor and rural populations. It also demonstrated the potential of demand side financing as a tool for improving health outcomes in public health programs. Furthermore, JSY created stronger coordination between the community health workers, particularly ASHAs, and the health facilities, as they played a vital role in motivating and escorting these pregnant women for safe deliveries. The scheme also contributed indirectly to improve neonatal survival and early postnatal care by ensuring mothers received timely medical attention. Despite some challenges, such as delays in payments and regional disparities in coverage, JSY remains a landmark milestone in India's maternal health journey, serving as a model for incentive based public health interventions globally. The National Urban Health Mission. This was launched in 2013 to specifically address the health needs of India's rapidly growing urban poor population. Despite being in proximity to major hospitals and medical colleges, many urban slum dwellers lacked access even to basic primary health services. NUHM aimed to bridge this critical gap by extending reproductive, maternal, newborn, and child health services to underserved urban communities. It recognized that urbanization brought unique health challenges, including overcrowding, poor sanitation, air pollution, and a high burden of non communicable diseases. By targeting slums and vulnerable urban groups, NUHM sought to reduce glaring health inequalities within these cities. The program highlighted the importance of moving RCH services beyond rural settings into urban contexts, ensuring health equity across geographies. It also encouraged states to develop innovative outreach models such as urban primary health centers, mobile health units, and community link volunteers. NUHM promoted intersectoral collaboration with urban local bodies for sanitation, water supply, and waste management, acknowledging that health outcomes are shaped by broader living conditions. Furthermore, it strengthened data driven urban health planning and established urban health and nutrition days to provide regular preventive and promotive care. Together, these measures made NUHM a vital extension of the RCH framework into the urban landscape, integrating inclusively innovation and sustainability. The RMNCH plus A strategy, launched in 2013, it marked a major milestone in India's health planning and policy integration. It brought together reproductive, maternal, newborn, child, and adolescent health under one unified framework, ensuring that interventions that were no longer implemented in silos. The inclusion of adolescent health was a particularly significant development as this age group has long been overlooked in earlier programs. The strategy introduced a concept of continuum of care, emphasizing that health services must be connected across life stages, beginning from pre pregnancy and pregnancy to childbirth to childhood and finally to adolescence. This ensured that care was comprehensive, continuous, and family centered, addressing both preventive and curative needs. RMNCH plus A strengthened linkages between facility based and community based services, promoting referral mechanisms and supportive supervision. It also aligned India's national priorities with global frameworks such as Every Woman, Every Child initiative and the Sustainable Development Goals. The addition of A for adolescents reflected India's growing recognition that long term reproductive health outcomes depend on early investment in adolescent well being. Furthermore, RMNCH plus A introduced five thematic pillars: reproductive, maternal, newborn, child, and adolescent health. each supported by specific interventions and measurable targets. This integrated life cycle approach transformed India's health system planning from a programmatic model to a system based, continuum oriented framework that continues to guide RCH policy even today. In the last decade, several focused initiatives were added to strengthen RCH further. The Indian Newborn Action Plan was introduced to bring down neonatal mortality, which remained stubbornly high. Mission Indradhanush aimed to achieve universal immunization by targeting children who had been left out of routine services. Lakshya focused on improving the quality of care in labor rooms and maternity wards. Poshan Abhiyan was launched to address malnutrition among women and children. These initiatives showed the government's willingness to respond to persistent gaps with target programs. They also emphasized that continuous innovation is necessary even when broad programs are in place. The new policy emphasized universal health coverage and continued to prioritize RCH as the key indicator of health progress. It set ambitious goals like reducing IMR, MMR, and improving fertility rates in line with Sustainable Development Goals. India's long history of RCH program has produced clear improvements in health outcomes. The maternal mortality ratio has declined steadily, showing that fewer women die during pregnancy and childbirth. Infant and child mortality rates have also gone down. More women are delivering in institutions, and immunization coverage has expanded significantly. Antenatal care coverage has improved across most states, though gaps remain. These achievements are the result of sustained investment and innovation over decades. They show that long term commitment to RCH pays off in measurable health gains. Despite progress, major challenges remain in reproductive and child health. There are sharp differences between states, with some achieving excellent results and others still struggling. Rural and urban areas show disparities, with rural population often receiving poorer services. Quality of care continues to be uneven, and not all women experience respectful or adequate treatment. Adolescent health is still not addressed strongly enough, even though this is a critical stage. Male involvement in reproductive health and family planning is limited, leaving the burden mostly on women. These gaps they remind us that improving access alone is not enough. Equity and quality must also be ensured. Looking back at India's RCA journey, several important lessons emerge. Integration of services is more effective than separate fragmented programs. Community participation is essential to build trust and ensure use of services. Decentralized planning works better because it adapts programs to local needs. Flexibility in policy design helps address the diverse realities of different states. Sustained investment and continuity over decades are needed to achieve long term impact and gain in long term goals. Finally, right based approaches that respect individuals' choices are more sustainable than coercive methods. These lessons continue to guide health planners in shaping future strategies. India's journey in reproductive and child health is tapestry of milestone shifts and unfinished tasks. We moved from early population control framing to the right based continuum of care approach of RCH and later RMNCH plus A backed by NRHM, JSY, JSSK, Lakshya, Poshan, HBNC and health and wellness centers under Ayushman Bharat. These programs reoriented the system towards first contact care, financial protection, and respectful maternal care, and they embedded the idea that data must drive action. Yet gaps persist. Stark interstate and intrastate inequities, poorer quality in high volume facilities, adolescent anemia, urban slum vulnerabilities, and fragile referral and transport in hard to reach geographies. Migration, climate shocks, and antimicrobial resistance are new pressures that demand nimble policies, stronger supply chains, and community owned preparedness. Progress has always accelerated when political commitment, frontline leadership, and community participation align with simple, reliable routines in the last mile. Our task now is to deepen quality, competency at birth, respectful care, postpartum contraception by choice, and to hardwire equity using Hamlet level scorecards, grievance redress, and transparent dashboards. Digital tools can help, but they must complement, not replace, trust, communication, and accountability. Understanding this evolution equips us to design policies that Understanding this evolution equips us to design policies that are adaptive to social realities, attentive to gender norms, and anchored to human rights. It reminds us that improving maternal and child health is not only about better indicators, it is an agenda of social justice, poverty reduction, and human capital. Nation building, one safe birth, one thriving child, and one empowered family at a time. Thank you so much for listening attentively. Now we will continue in lecture 3 with definition and scope of reproductive and child health. Thank you.